Team, we are welcoming you again with the second day of the basic course of the ultrasound with the ERA committee. And today we have a rich program to cover the lower limb and also the a very interesting talk about the Doppler itself in musculoskeletal ultrasound. And I'm very happy to actually present my friend, Dr. Professor Hala Faid from Qasr Aini Hospital. Dr. Hala, she's graduated from Qasr Aini Hospital and working now as an associate professor in the university. She's known in the musculoskeletal ultrasound training, and she's a colleague within the RLAR ultrasound interest group. She's already presented us about the Doppler signal or Doppler ultrasound in rheumatological indications. Without further delay, Professor Hala, the floor is yours.
Okay. Good afternoon, all. I'm glad to participate in the Emirates Rheumatology Academy Basic Musculoskeletal Ultrasound course. I'm very thankful for the invitation by the members of the Academy and Professor Dr. Ahmed Abu Gamal. My talk today will be about Doppler physics, setup, and artifacts. And my agenda will pass through these topics. First, what is Doppler ultrasound? Types of Doppler, uses, Doppler setting optimizations, some scanning tips, and Doppler artifacts. So what is Doppler ultrasound? This is part of the vascular ultrasound, which is a medical non-invasive imaging modality that uses high frequency ultrasound waves to visualize and study blood vessels and their pathologies. So what is the history of Doppler? Actually, it was as early as 1843. It was named after the Austrian physicist and mathematician Christian Andreas Doppler, who described it for light, and he actually stated that the observed frequency of a wave depends on the relative speed of the source and the observer. And this theory he started was a real important theory, and it was based on it many things afterwards. It was said as the effect that changed the world, and despite many other inventions afterwards, it was in the 2003, it was declared as the effect of the millennium. And Albert Einstein also said that regardless of what form of the theory of electromagnetic processes will take, the Doppler principle will certainly remain. The hypothesis was then tested for sound waves by a Dutch chemist and meteorologist in 1845, and he confirmed that the sound pitch was higher than emitted frequency when sound source approached him, and lower than emitted frequency when sound source receded from him, as we will see afterwards. And in Britain, also, John Scott Russell made an experimental study of Doppler in 1848. So how does Doppler work? It actually works through what is called Doppler effect or Doppler shift. And what is Doppler shift? This is the change or shift in the transmitted ultrasound frequency when reflected by moving object, and in our case, it is the RBCs or erythrocytes. And it uses the sound waves to create the images of blood flowing in veins and arteries. This is translated into color information superimposed on B-mode grayscale image, as we see here. The emitted ultrasound waves hits the moving RBCs and then reflected to give us information about the blood flow. And actually, it is the difference between the transmitted and the received frequency, and it is calculated in hertz. And it, according to the equation, it is the difference in the frequency, or the frequency shift, is 2 times the transmitted frequency multiplied by velocity and cosine the angle of insonation. So all these factors are directly proportional to the Doppler shift. The transmitted frequency, that is the line in blue, the frequency emitted, and the velocity of the blood flow, and the insonation angle, that is the angle between the ultrasound beam and the blood flow. We will speak about these factors separately. The transmitted frequency. We can explain this as the sound of a moving ambulance or a police car. Usually, the one behind the car will hear the voice lower, and the one in front will see the sound higher. This is due to the difference in frequency, because as the car leaves, the sound wave frequency is low behind, and it will be high above due to behind for rarefaction, and in front of the car due to compression of the sound waves. So the change of sound pitch here when ambulance or police car sounding a horn approaches and recedes from an observer, the received frequency is higher compared to the emitted frequency, identical at instant of passing by, and lower during recession. The only one who hears the actual frequency or sound frequency is the one inside the car. So the faster the blood flow, the greater the Doppler shift. Here also we will discuss that the blood flow is expressed as positive or negative value depending on the direction of blood flow relative to the ultrasound beam. So if the motion is towards the transducer, we'll have a high frequency that is in front of, so we'll have a positive Doppler effect, and motion away from the transducer, as the case behind the car, will have lower frequency and negative Doppler effect. Another thing is the velocity of blood flow. The faster the blood flow towards or away from the transducer, the greater the Doppler shift. And this is a form of spectral Doppler with various velocities, as we see here in the image. The third factor is the Doppler insonation angle. And as we mentioned, it is directly proportional to the Doppler shift. It is the strongest signal of Doppler when motion is parallel to the beam. And why? Because the equation states that it is cosine the angle, and as we all know, cosine 90 is 0. So if the beam is perpendicular, we will have no Doppler shift. And if we have a big angle above 90, we will have no Doppler at all. And the optimum angle is 45 to 60 degrees. And when examining small blood vessels not visible to the eye, as in the synovium, it is not possible to identify insonation angle or perform angle correction. So angle correction is of importance in the color Doppler when examining large vessels, as in vasculitis. So what are types of Doppler? We have the color Doppler, the power Doppler, and the spectral Doppler. And here we have first to know what is duplex. Is it the same as Doppler? Actually, duplex is Doppler ultrasound imaging superimposed on a gray scale image. It is a synonym of vascular ultrasound. And what is color Doppler imaging? We actually, the Doppler shift calculated is imposed as color in this type of Doppler ultrasound. It produces a color-coded map of Doppler shift superimposed on a V-mode ultrasound image. It is very useful in identifying actually the overall view of the flow. the velocity of the flow and direction of the flow. As we mentioned, it is red if it is towards the transducer, or blue if it is away from the transducer, and it imposes it in color, displays it in color. And according to the color map in the upper left corner, the red color on the top of the bar denotes the flow coming towards, as we mentioned, and the blue means away from it. So these are the advantages of the color Doppler. So what are the limitations? Actually, it is semi-quantitative. It is angle dependent. It is subject to a Doppler artifact that we'll talk about later is called aliasing, and also noise artifacts. Besides, it has poor temporal resolution, that is resolution in relation to time. The second type of Doppler is power Doppler imaging. This is based on the amplitude or power of Doppler signal, which means the brightness or the hue, which represent the power or intensity of returning echoes, rather than frequency information. So it has nothing to do with direction or velocity. It only shows the presence of the flow and movement patterns. And this is the one we use it usually for inflammatory conditions and for small vessels and low velocity flow. This is the one we mostly use it in rheumatology. What are advantages of the power Doppler? Actually, it is very sensitive. Its sensitivity for detecting flow is 3 to 5 times higher than conventional color Doppler. And as we mentioned, it is suitable for assessing small vessel flow and low velocity flow. It is less dependent on flow, direction, and angle, and it has no artifact of aliasing in it. However, it has got some disadvantages, as its susceptibility to what is called motion or flash artifacts, as we see here. This is the flash artifact, because it is too sensitive and captures movement of the surrounding soft tissue. So moving the transducer or patient movement can cause such artifact to appear in power Doppler. The third type is the spectral Doppler imaging. This type of Doppler, we can see and hear the blood flow. Ultrasound is emitted in pulses, and gate is used to determine interval after emission when returning signals are received, therefore the depth from which sample is taken. And Doppler shift data is displayed here in graphic form. And not only, as we said, do we see the graph and the velocity, and we can examine the waveform, but also we can hear the blood flow. In this case, higher velocities will give a high-pitched sound, and lower velocities will give a low-pitched sound. Here is the spectral Doppler imaging. What it actually does is it breaks down the complex ultrasound signals received by the RBCs. Actually, they are different RBCs moving in different speeds and different directions. So it captures all the data from these RBCs. It makes an average frequency over a circumscribed time period, and then displays the blood flow graphically over time. And here is, as we mentioned, the duplex ultrasound, because some people got confusion between the terms. The duplex ultrasound is a combined technique using both B-mode grayscale ultrasound and Doppler ultrasound, where B-mode outlines the anatomic structure and the power Doppler shows the flow and movement patterns. So it gives information not only of the lumen of the and movement of the blood flow, but also gives information about the condition of the blood vessel. What are uses of Doppler ultrasound collectively? It gives information about the all the vascular system. It shows evidence of venous or arterial thrombosis or stenosis, and arterial occlusion or aneurysm. It can detect measure, quantify blood flow, assess patency. It can show the direction of flow, as we said, in the color Doppler, and it can show the absolute flow volume estimation and volume over time. As in spectral Doppler, it can moreover estimate the what is called arterial resistive index. This is all about the lumen, but what about others? Can assess the blood vessel wall, can show the thickening or thinning or aneurysmal dilatation or precipitated plaques in the inner side of the wall. And more, it can detect neovascularization, the thing we use it most for inflammatory conditions and detecting disease activity in our rheumatologic diseases. So Doppler ultrasound largely depends on many factors. Actually, on the device or machine, that is the sensitivity and optimal image settings, and the structure, which is the blood vessel, the depth, the course, all affect the Doppler ultrasound signal, and finally the operator or the examiner. So knowledge of the anatomy and pathology, together with skills in positioning and applying adequate pressure and adjusting the angle, all these factors contribute to a successful Doppler ultrasound scanning exam. So we'll then talk about the second part, which is the Doppler settings or setup for the Doppler scan exam. The most important points are selection of the appropriate Doppler type. So you have to know when to use color Doppler and when to use power Doppler, when to use spectral Doppler, and so on. Second is the Doppler frequency. Also the pulse repetition frequency, the wall filter, the velocity scale, the Doppler gain, the Doppler box size and position, and the Doppler angle, and we will just mention each one of them separately. So as regards the selection of the appropriate Doppler type, generally color Doppler is useful to detect high velocity flow and large blood vessels. So it is mostly useful in cases of vasculitis or in examining large blood vessels in general for atherosclerosis and so on, or aneurysms or so on. The power Doppler, as we mentioned, is crucial, or is very useful for defining low velocity flow and small blood vessels, and that is why we use it for neovascularization and small vessels in synovium and tendons and so on, and detects disease activity in rheumatologic diseases. However, in newer high-end machines, color Doppler may have higher sensitivity than power Doppler. What about Doppler frequency? Actually, we have just Doppler frequency and independent of the B mode frequency adjustment. And lower Doppler frequency allows more penetration, but with lower resolution, the same rule as we use for the B mode. And it is used to map deep blood flow with very high velocities to circumvent aneurysm. And the high Doppler frequency gives better resolution, but at the expense of penetration. So we have to know what we need in each particular examination, because there is a compromise between sufficient penetration and adequate sensitivity. And optimal Doppler frequency should be adjusted by oneself after repeated trials. Actually, there is no particular adjustment for doing Doppler ultrasound exam. So you have to try it with your machine and your patient. First of all, you try it on normal people, and then you try it on some pathologists till you have the appropriate adjustment for your machine. What about pulse repetition frequency? We can speak about it like if you're shooting birds and using gun for shooting birds, so you shoot multiple shots, and ultimately you will pick one or two birds. So the pulse repetition frequency is the number of ultrasound pulses emitted from the transducer as the gun in 1 second, and it is reported in kilohertz. The range is usually between 500 and 950 kilohertz. Increasing the scanning depth will decrease the PRF, so more time is needed for echoes to return. But at minimum, PRF must be at least twice frequency of the Doppler signal. And adjusting PRF is simultaneously, there is adjusting the wall filter, that is called, there is a link control. For superficial structures, we use a low PRF as low as 700. And for low velocity flow, we use again low PRF, as in inflammatory lesions. And for high velocity flow, we use high PRF. And note that you have to adjust the PRF setting to the lowest possible to see the signal. The wall filter, we can say it's about like something like the sieve, and it is the principal base for the radar. Its value is to cut off low frequency noises, so a cleaner display of high velocity blood flow signal is received. Again, as we said, that the PRF and wall filter are proportional to one another, or they are linked together. So it is again set at the lowest level. So you set the wall filter at the lowest, then you gradually increase it until a clear image is obtained. This is the opposite of what we'll see in the gain afterwards. But if wall filter is set too low, the noise will be more pronounced, and if set too high, the blood flow will not appear. Again, there is an item related to the PRF called the velocity scale. It controls the displayed range of frequencies by adjusting the PRF. And if too high scale, the dynamic range is too high, and low velocity signals will be missed. And if too low, the dynamic range is again too small to display high velocity signals, then this will result in the artifact called aliasing. What about Doppler gain? The Doppler gain, as we heard yesterday, that it controls the amplitude. This is the amplitude, the height of the Doppler signal, or the brightness of the color displayed, both in color Doppler or power Doppler. But if the gain is increased too much, then there will be noise and overestimation or overestimation of hypervascularization. And if set too low, again, there will be underestimation of hypervascularization. So adjusting gain is crucial for accurate picking of the hypervascularization. And opposite to what we said in the PRF, here we are to adjust the Doppler gain. First, we set the gain as high as the noise appears, then we decrease it gradually till noise disappears. Very important is to adjust the Doppler color flow box. This box, once you open the Doppler, it will come to you, this box. You have to adjust to put it as superficial as possible, and to make the size of it as small as possible and appropriate to what you're examining. So the Doppler box or sampling box is divided into cells, and each cell behaves like an independent Doppler gain with its own Doppler analysis. And as we said, should be as small as possible, but as large as necessary and as superficial as possible. A small box can increases, and a small box size increases and frame rate increases resolution. And oversized box decreases the frame rate and decreases resolution, as we will see here. So if we have an oversized box, this will decrease the frame rate and the clarity of the image, that is resolution or 2-point discrimination, as we heard yesterday. And if there is reduced color box size, there will be increased frame rate and increased resolution. Another important thing that we can use the box as a rectangle, but sometimes we can use the steering as a method instead of the intonation angle. So we use the steering method, as if we are inclining the ultrasound beam. If we have a small angle, as we said, 60 and less, we have a good image. And if we have a large angle, we'll have a bad image. And here are examples of the steering. That minimal steering gives a good image, but if we increase the obliquity, we can get artifacts, and we can get a bad image. And here are some tips for making a proper Doppler ultrasound scanning examination. That we have to have an adequate pressure, and the adequate pressure is calculated as if you're putting a bar of soap or pressing a bar of soap on the body surface of the patient. And second is the proper angle of insunation, the 60 or less, which is achieved by tilting the probe or sample box. And consider the anatomy, because some feeding vessels may be there, should not be mistaken for Doppler activity. Also, some anatomic variations that has to be considered, and examine structure in a relaxed state. And here's one nice paper for joint examination, matter for ultrasound examination of a patient. Increased power Doppler signal in neutral versus flat position of the hand. The neutral position is slightly flexed, fingers and wrist. This is a better positioning than using the flat position of the hand, and it allows the blood vessels to appear, and finally compare with the other side if normal. Now we come to the last section of our presentation today, that are the Doppler artifacts. And firstly, we need to know what is an artifact. So an artifact is any change in image that does not represent an actual image, and it may mimic an abnormality while scanning normal structures. However, in Doppler, artifacts are natural part of the examination, so we just need to be accustomed to it and know that they are just mere abnormalities, and they should not disturb our image interpretation. To understand or study more the Doppler artifacts, we can classify them into artifacts due to technical limitations, or artifacts due to patient anatomy, and finally artifacts due to machine factors. The most important of which are these due to technical limitations by the ultrasound beam, and that we will study them in more details, are the aliasing, the random noise, the blooming, or the color bleed, the reverberation. Others are directional ambiguity, partial volume, and absence of flow. So what is aliasing? Or in other words, they are called PRF aliasing. This is, you find pixels of different colors coming inside the blood vessel. It is an inaccurate display of color or spectral Doppler velocity when velocity range exceeds the available scale. As we mentioned earlier, if the velocity scale is very high, above what is called the Nyquist limit, we find this Doppler artifact. Signal falls over, showing pixels with an opposite direction than surrounding flow, so it shows a false velocity of the displayed flow. And how to overcome this artifact is the PRF may be increased, or you may increase the insunation angle of the transducer to avoid this artifact. But note that if you increase the increasing the PRF will decrease the sensitivity to low velocity flow, as we mentioned earlier. And also note that power Doppler has no aliasing, again, as we mentioned in the previous slides, because it has no directional or velocity component. The second artifact is the random noise. which occurs when the gain is too high. So this is the picture we will have when we raise the gain initially, and then we try to lower the gain until we reach a clear image with only the Doppler signals desired to be studied. So it is easily identified as colors that as colors never reappear in the same location as true flow does. So the true flow is usually fixed. Yeah, it comes and goes, but it is in the same place. But usually the artifacts are running here and there and not in the same place. To avoid random noise, as we said, we have to adjust the gain correctly. The third artifact we'll speak about today is the blooming. Another name for it is the color bleed. So as it's as if the vessel is bleeding, as if the color is bleeding outside. So this, if you don't know this artifact, you may say that this is a leaking from the blood vessel or so. So color bleeding overlap blood vessel wall make them look larger than they really are. And again, it is the exaggeration of the previous artifact actually. So exaggerated noise is will lead to blooming. If you don't know about it, again, you may mistake a thrombus or clay, and adjusting the gain is the solution for this artifact. The fourth one is the reverberation, and we heard about it yesterday again, that, for example, the needle will have multiple lines parallel to one another, because the ultrasound beam encounters two strong parallel reflectors, so it reflects back and forth between them. That is to say, it reverberates. So the ultrasound transducer interprets these waves returning as deeper structures, since it took longer for a wave to return to the transducer. An important example for this is a superficial blood vessel, may be repeated in the lower image, as this image shows also. Again, if there is calcifications, it can cause this, again, this ping pong or reverberations, and will result in reverberation artifact. And the only solution in this case, if there is a calcification in some place, you have to change the position where you are standing to where there is no reverberation. And again, always make sure that the color box goes to the top of the, and this is superficial on the to the your image. The second group of artifacts, we will mention the flash artifact or motion artifact. This is usually due to more movement of the transducer or the patient, or movement of the tissue or blood vessel itself. It gives short flashes of large confluent areas, as we see here, and it is usually seen in hypoechoic areas as cysts and fluid collections. But note that these flash or motion artifacts are not pulsating. And again, as other artifacts, they seldom reoccur in the same place. So they change their position. And so most artifacts usually change their positions, and this is a discriminating feature as well. And motion artifacts from tissue movements as blood vessel wall may be avoided by adjusting wall filter, as we mentioned earlier. Here are grades of flash artifacts in power Doppler. So in these two, you will perceive them as artifacts, but in this particular image, because it is not too much, you may perceive it as a power Doppler signal. But note that there is they are coming behind a cortical, an intact cortex, which means that these are artifacts are not true Doppler images. Another one is the mirror artifact. This is as you seeing your shadow in the river or so. It displays objects on both sides of a highly reflective surface. So if this is a moon or some, you see the Doppler signal above and below this reflective surface, which acts as acoustic mirror. Actually, it directs some echoes to second reflector before it returns them to the transducer, making a multi-path reflection. Well, and actually this artifact is easily identified when you can find the true image, which is the blood vessel, and the mirror, which is the bone, and the mirror image all in one image. But it comes difficult when you find only the mirror and the mirror image without finding the reflective surface. And if investigated with spectral Doppler, it will show true flow because it is a mirror of image of true flow. Remember that true flow, Doppler activity are never seen inside bone if bone surface is intact. And we stressed on this many times throughout our talk. The last one we'll talk about from the third group is the twinkling or scintillation. These appear as discrete focus of rapidly fluctuating or alternating Doppler signal behind, again, a strongly reflecting interface as calcifications, and it is a resultant of attenuation of ultrasound beams, and it is dependent on the machine settings. So to wrap up, Doppler ultrasound is based on Doppler shift. Selection of the appropriate type of Doppler for each examination is crucial, and knowledge and optimization of Doppler setting is of paramount importance for successful examination. Skill and lengthy training is necessary, and knowledge of Doppler artifacts allow avoiding wrong information. And thank you.
Assalamu alaikum, Dr. Hala. Thanks for your thank you, Dr. Hala, for the nice talk covering all the aspects of the power Doppler and our specialty. And please, if you have any questions or queries, please keep it in the chat box. We'll answer all the questions after the last talk. So now we are moving forward to our second speaker today, and actually great pleasure to me to present my close friend Slavica Burdanovic from Belgrade Institute of Rheumatology. Slavica have a long experience in rheumatology, working over 30 years in serving patients with arthritis, and also has a great experience in ultrasound teaching and practicing for over a long time. She dedicated mainly in participating in different training courses, and already she has a large certified ultrasound teachers and experts. Today, Slavica will giving us a nice talk about the basics of hip ultrasound. Slavica, the floor is yours.
Hello to everyone. First of all, I would like to express my gratitude for being inviting to present my lecture about ultrasound examination of the hip joint. So that I would like to thank you, Professor Abogamal, and all his friends that are organized this wonderful meeting. So hip joint is a very important joint of our body, of course, like many others. But this joint provides different, very shape range of motion that allow us everyday activities. The topics of my lecture would be anatomy, then some ultrasound examination, and basic pathology of hip joint. First, anatomy. As you know very well, hip joint is a big synovial joint with relatively complex anatomy, but I'll try to stress the main anatomy structure step by step in order to clarify this anatomy position. So I will speak you about bones and joints first, then about ligaments of the joint capsule, and muscle and tendons, and the end some words about nerves and blood vessels. First, bones. As you know very well, the hip joint is being building by articular surface of the hip. Actually, this is head of femur and part of neck, and the articular surface of the acetabulum, actually the socket of acetabulum. As you can see, both articular surfaces are covered with a big amount of cartilage, and we have additional layer from external side called acetabulum limb or acetabulum labrum, so that this joint could be smoothly moving in different aspects. In this image, you can see all those important structures from anterior side. Again, you can see articular surfaces of acetabulum. You can see articular surfaces of the head of femur. You can see femoral neck, and you can see two bony prominences. First one is greater trochanter, and the last one is a lesser trochanter. As you can see, there is some invisible line that is calling intertrochanteric line. That is very important line where anterior part of joint capsule is attaching to the bone surface. From posterior side, we have intertrochanteric crista, where posterior part of articular capsule is attaching to the bone. What about the ligaments of the joint capsule? We have three main ligaments from anterior side. We have iliofemoral ligament, which is Y-shaped. Then from inferior side, we have pubofemoral ligament. Then from posterior side, we have ischiofemoral ligament. All those ligaments are very strong and as you can see, participate in building joint capsule actually. So that it's very important for hip movement, of course. Then I will speak you about muscle of the hip. There are two groups of muscle. We have thigh muscles and gluteal muscles. Thigh muscles are divided into three groups, into two compartments actually, anterior, medial, and posterior compartment. I will explain the muscle of each compartment. So first, anterior compartment level, pelvis level, we have, as you can see, iliopsoas muscle. This muscle is consist of psoas major muscle and iliacus muscle. As you can see, both is attaching to the lesser trochanter. This muscle is powerful flexor of the thigh and the hip joint. Then we have another three muscle of anterior side. We have tensor fasciae latae muscle, sartorius muscle, and quadriceps muscle. And all those muscles respond, provide us flexion of the thigh at the hip joint and extension of the leg at the knee joint. Quadriceps muscle, as you know very well, is consists of four muscles. First muscle, rectus femoris, which is the longest muscle in our body. Then vastus intermedialis. Then vastus lateralis. And then vastus medialis muscles, green colored, all green colored, as you can see. Then we have sartorius muscle. Sartorius muscle has proximal attachment of the anterior superior spine, iliac spine, and distal attachment at the level of tuberositas tibia. And as you may know, this tendon of sartorius muscle together with the tendon of gracilis muscle is forming pesanterinus structure. Then more laterally, we have tensor fasciae latae muscle. This muscle has proximal attachment at the level of anterior superior iliac spine, and distal attachment at the level of tuberositas, at the level of jetty tuberculum, actually, on tibia bone. And this muscle has a big tendon named iliotibial band that you know very well. Then we are moving to medial part of an anterior compartment. We have three main muscles: obturator extensor muscle, then pectineus muscle that is more medially, and gracilis muscles. All those muscles are provide us flexion and rotation to the thigh. And we have adductor of the hip, adductor actually of the thigh from deep to superficial side. We have adductor brevis, as you can see, green colored. Adductor longus, and the most superficial is adductor magnus. Okay, we are moving to posterior compartment. At that side, we have three muscles called hamstring muscle. Actually, we have biceps femoris muscle. We have semitendinosus and semimembranosus muscle. All those muscles provide extension of the thigh at the hip joint and flexion of the leg at the level of the knee as well. This is biceps femoris with caput mediale and caput laterale. This is semitendinosus muscle, and this is semimembranosus muscle, more superficial. And the end, we have group of gluteal muscles. As you know, we have gluteal minimus muscle, the first on deep location, then we have gluteus medius muscle, and the more superficial is gluteus maximus muscle. Those muscles provide extension and abduction of the thigh and the hip joint. Some words about nerves and arteries. As you know, from anterior side, the biggest nerve, the most important nerve and visible nerve is femoral nerve. And from posterior side, we have sciatic nerve and their branches, of course. What about artery? The main artery of anterior side is femoral artery and their branches. And as you can see, this artery is more medially concerning joint recess, so that don't be afraid when you perform intra-articular injection. Then we are moving to the ultrasound examination. What about ultrasound examination of hip? So before 1917, the main clinical method of exploring hip pathology were CT, radiography, or MRI. But after that, when ultrasound method was introduced in our rheumatology practice, the result of many clinical articles and studies suggests us that many hip diseases could be very detectable by ultrasound. But always keep in mind that this method has relatively limitation due to deep location of hip. The main things when we perform ultrasound examination of any joint is patient position. So in examination hip joint, patient lies on his back. As you can see, the knee are fully extended and the heels are joined together. We are using low-frequency linear, either convex probe. In our everyday clinical practice, we usually explore anterior and lateral part of a hip joint. Let's see ultrasound examination of anterior part. As you know, as I mentioned before, at the anterior part of hip joint, we have joint capsule. Actually, we have iliofemoral ligament that are covered joint recess. So keep in mind this anatomical image in order to put linear probe just over this anatomical position in order to be exact, in order to obtain ultrasound images like this so easily. On this image, you can see some hyperechoic line. The first one belongs to bony profile. You can see part of acetabulum. You can see part of femur. This is a femoral head, and this is a femoral neck. And you can see another hyperechoic line. This line belongs to iliofemoral ligament, as I mentioned before, and the more superficial is line that is belong to joint capsule. So the space between bony profile and those hyperechoic line, of course, belongs to anterior joint recess of hip joint. And as you can see, we a part of this structure mentioned before, we have muscle. First muscle that is so close to joint recess is iliopsoas muscle. Then we have rectus femoris muscle, and the top of this image, sartorius muscle is located. This is a transfer view of hip joint. You recognize a hyperechoic line that belongs to bony profile of femoral head, and you can see another hyperechoic structure that belongs to iliofemoral ligament. And if you are moving a little bit medially, you will find so easily neurovascular structure, femoral artery, vein, and nerve. We are going to explore lateral part of the hip joint. In this position of patient, you put linear probe just over the anatomical structure on this region in order to perform ultrasound image. As you can see, if you put this probe just over the structure, you will find tendon, iliotibial band, and tendon of gluteal muscle, and bone would be trochanter, greater trochanter. So this is your bony landmark in longitudinal view. This is a hyperechoic line that belongs to greater trochanter. And the first hyperechoic band over this bony surface belongs to gluteus minimus tendon. Then upper part belongs to gluteus medius tendon, and on the top we have the biggest tendon that belongs iliotibial band, actually tensor fascial lateral tendon. So this is a normal appearance in longitudinal view of greater trochanter. This is a transverse scan. This is anterior part. This is posterior part. Line of greater trochanter, and you may see another again a hyperechoic part that belongs to three tendons: gluteus minimus, medius, and tensor fascial lateral tendon. And the end basic pathology of ultrasound finding of hip joint at the level of the hip joint. I will speak you about bone and cartilage pathology, joint pathology, and tendon pathology. On this image, you can see normal ultrasound appearance of all the bony surface of the hip joint. And on this ultrasound image, you can see the main difference. You may see bony cortex breakdown. And on this image, it could be seen better due to big calcification or some fracture. And regarding calcification, on these ultrasound images, you can see a group of small calcification. If you expand this image, you can see it better. Many small calcification at the level of acetabulum and part of femoral head. And you may find singular small calcification as well. Why not? And this is small calcification of the level of acetabulum. Of course, this is degenerative hip illness. And this image is ultrasound image is very interested, and I would like to be more patient to find very interesting things. As you may notice, at first we have very big calcification at the level between acetabulum and the head of femur. And you may notice this parallel hyperechoic thin line together with this calcification. And if you expand this image, you will see another this actually hyperechoic line better. So on this image with the same patient, we have two crystal disease illnesses. We have chondrocalcinosis and gout. Ultrasound method is actually the most useful method for making diagnosis of crystal arthropathies. So you may find the sign of these crystal arthropathies even at the hip level. We are moving to pathology of joint recess. This is a normal aspect, and you may see difference concerning this line. Actually, this line belongs to joint capsule, and as you may notice, this line is so distended due to synovial proliferation inside and and you may note anechoic structure that belongs to joint fluid inside of hip joint. And some osteophyte as well on this part. And another hip effusion at the level of the joint. When you measure this distance, it is recommended that cutoff is 8 and more than 8 millimeters. Another fluid within joint recess. And calcification as well, and another dissection of the joint capsule. Well, in the end, I will speak you some words about basic pathology of trochanter. This is a normal echostructure of greater trochanter. And you may see the difference. You may notice some small calcification in the longitudinal scan. Then this is a smaller one, calcification. Actually, sorry, bigger one. And you may find irregularity of bony cortex that is also belongs to tendon and tensopathy. You may see that cortical surface is not intact like normal should be. And this is transfer scan. This is a normal appearance of greater trochanter at the level of transfer scan, and you may notice the difference. You may see some small calcification at the level of greater trochanter and some anechoic structures around the bony surface. So this anechoic structure belongs actually to peritrochanteric bursa, as you may see on this image as well. Anechoic structure with the fluid, and sometimes you may obtain power Doppler at the level of this bursa. In this case, the power Doppler is weak, but is still present. That reflected bursitis and tensitis as well. So that is all from me. Many greetings from Serbia, from Belgrade, and thank you for your attention.
Thank you, Slavica, for a nice presentation as always, and thanks again for being with us. For all attendees, please, if you have any questions regarding the first or second talk, please put them in the chat box. We came back for all questions after the last presentation. Now we are moving forward towards the third talk today regarding the second joint region in the lower limb, which is the knee joint. Knee joint will be presented by my friend and colleague, Dr. Rita Harifi. She is already a board member of the Emirates Rheumatology Academy. And Rita is already a board certified rheumatologist from Sorbonne University in Paris, France. And she's already has holding the ULAR teachers certificate, second level competence of the ultrasound as an instructor and teachers, participating in different training courses over the country here and over the Arab countries, as a member already of the ARLA ultrasound group. So the floor is with Rita now for the knee ultrasound, basic ultrasound scan.
Everyone. It's a real pleasure to take part in this musculoskeletal ultrasonography course presented to you by IRA, by the Emirates Rheumatology Academy. And I'm very pleased to be talking about the ultrasonography of the knee, trying to take you to the actual technique of examination, and I'll try to show you a few pitfalls to be avoided during that journey. Now, usually when we talk about knee imaging, the first technique that comes to our mind is MRI. But in fact, ultrasonography offers a unique strength over the MR imaging. The low cost, the portability makes it much more available than MRI. Ultrasonography has also a higher spatial resolution than MR imaging and may be helpful in evaluating the superficial structures of the knee, for example. One of the most important advantages of ultrasonography versus MRI, in my opinion, is the dynamic examination, the possibility of examining the structures while moving the joints, which is not offered by MRI, and which can be particularly helpful in differentiating partial from complete tears involving the quadriceps and patellar tendons, for example. Another advantage of the ultrasonography is that it allows you to proceed with ultrasound-guided injections, which have been shown to be much more accurate than the blind injection. Ultrasonography also allows a direct contact with the patient. It does allow you to show the patients what's going on as you're examining. It does facilitate an immediate clinical correlation. You examine the patient clinically, then you show him what is going on the ultrasound immediately afterwards. It offers also the possibility to compare with the contralateral knee, which is more complicated when it comes to the MRI. Some technical considerations before we start the actual, examination. Ultrasonography evaluation of the knee is primarily performed with the patients in the supine position, with the obvious notable exception of evaluating the posterior structures for which the patient lies prone. Scanning is performed with a high frequency probe, ideally above 12 megahertz. Most of the structures are superficial structures, so we need a high probe with a high resolution, high frequency, and linear transducer, obviously, although a lower frequency transducer is sometimes better, or at least an adjustment of the frequency in the settings is sometimes important for evaluating the deep posterior structures. Now, the most important message that I can give you regarding the ultrasound examination of the knee is to be systematic. Whether the patient is coming for an anterior knee pain or a posterior suspicion of Baker's cyst, etc., be systematic. Examine the knee the same way you do it for any complaint, which means that go with the 4 steps: anterior knee, medial knee, lateral knee, then the posterior knee. And this is what we're going to show you here. So we start with the anterior knee, and I'm going to show you the ultrasound probe placement and positioning for each part of the examination. So for the examination of the anterior knee, the knee should be flexed. So we said that the patient is in supine position. The knee should be flexed for 20 degrees, 20 to 30 degrees maximum. And for that, a rolled towel may be placed under the knee for support. And remember that in the anterior knee, there are some important structures to be seen, and you should not be moving to the second part, of the next step before having examined these structures. So we'll be able in this examination to see the extensor mechanism with the quadriceps tendon, the patella, the patellar tendon, the suprapatellar joint recess, and we'll have to look at it in the, medially, from medial to lateral or lateral to medial, the anterior knee bursa and the femoral cartilage also can be examined at this step. Now, the evaluation begins with placement of the probe in the sagittal plane, just proximal to the patella, along the long axis of the quadriceps, of the quadricipital tendon. It is important to evaluate the complete quadriceps, okay, tendon, medial to lateral. So as you place the probe here, you place it in the middle, but you move the probe medially and laterally. This is important to evaluate the tendon, the totality of the tendon, but also important for the subquadricipital recess, as we're going to see, so you don't miss a small effusion, for example. This is a longitudinal view of the quadricipital tendon. As you place your probe this way, this is the image that you will be getting with the quadricipital tendon inserting on the patella at this level. You can see the fat pad in here, the femur. You'll be able to appreciate the typical aspect, hyperechoic fibrillary aspect, as you can see here, of the tendon. The quadricipital tendon is formed by a component from rectus femoris. Now, if you go to the transverse view, you'll be able, if you swap here the probe and you go to the transverse view, you can go a little bit proximally to appreciate the different components of the quadriceps muscle and then quadricipital tendon, with the rectus femoris in the middle, the vastus medius and vastus lateralis, and more deeply the vastus intermedius muscles. And then if you go with the TS view, if you go a little more distally towards the quadricipital tendon, you can appreciate here the quadricipital tendon, but you will be able to see the femoral cartilage. And this is an important, you might need to flex the knee a little bit more to appreciate the femoral cartilage. You can here obviously appreciate the thickness of the cartilage, and you can see some obviously thinning in degenerative conditions, in osteoarthritis. You'll be able to look for calcifications, intra-articular calcifications in chondrocalcinosis, for example, or calcifications sitting on the top of the cartilage for in gout, for example. So there are too many elements and information that you can get from this examination. Now, this is the image that you get in a longitudinal view, so of the quadricipital tendon. So this is the quadricipital tendon. You can see here the quadriceps fat pad. This is the prefemoral fat pad, and you can appreciate here a very tiny hypoechoic material here, showing a physiological amount of joint fluid. This is obviously acceptable in a normal joint to see a bit of fluid at this level. This is exactly what we'll be looking for, an effusion, for a joint effusion, or for a synovitis, for a knee synovitis. So this is the suprapatellar scan showing the suprapatellar recess with a normal amount of fluid. As we said, as we go, medial in the middle, we do that. Don't forget to swap and to go medially and laterally to scan the medial and the lateral, appreciating the parapatellar recess in here. With again a physiological amount of fluid, and the medial parapatellar recess with sometimes an effusion, and here a physiological amount of fluid. Now, on a transverse view, you have the suprapatellar, this is a suprapatellar scan showing the normal hyaline cartilage, as I showed you before. And this is also a very important scan to appreciate cartilage abnormalities going from osteoarthritis to metabolic diseases and so on. Now, that was the anterior knee in the suprapatellar part. Now, we go now to we're still appreciating the anterior aspect of the knee, but we go to the infrapatellar part of the examination. So all what we have seen now was suprapatellar. We go now below the patella and we start appreciating the structures below the patella. And here we have, obviously, you put the probe in a longitudinal view, proximally on the patellar insertion of the patellar tendon and distally on the tibial tuberosity. And you will be able to appreciate here, obviously, the patellar tendon with its insertion, proximal insertion on the patella and distal insertion on the tibial tuberosity. You can, so this is a longitudinal view. As you can also appreciate a transverse view of the patellar tendon with the this image is a TS view of the patellar tendon and the distal insertion on the tibia, and you can appreciate here its broad and flat structure, quite a flat tendon at this level. So this is the view I just show you, infrapatellar longitudinal scan showing the patellar tendon in here with proximal and distal insertion of the tibia. In this area you would appreciate the Hoffa pad, but sometimes you might get some fluid in here in the bursa, or so below the tendon or on the top of the patellar tendon, defining obviously the patellar bursitis, suprapatellar or infrapatellar bursitis. So you get these images usually using the panoramic views on the ultrasound on some machines that allows you to appreciate the tendon from the proximal to the distal. Very importantly, this is a very important actually scan when in psoriatic arthritis patients, when you would like to appreciate the existence of an enthesitis, so enthesis abnormalities at the level of the patellar tendon, proximal enthesis and distal enthesis. And in the literature, you have some indications of the normal thickening of this tendon, of this enthesis at the level of proximal and distal insertions, and you can appreciate. But the best way, obviously, to do it is to compare right and left side always. So this is a medial view, and this is a distal view showing the medial insertion on the patella and the distal insertion on the tibia. You can see the normal structure here, the fibrillar structure of the tendon, and the absence of any abnormality, any erosions, any at the insertion, any bone spurs indicating enthesophiles, for example. So this is a very important area to appreciate in inflammatory arthritis as well, and especially in psoriasis patients when you're looking for indication of psoriatic arthritis and enthesitis. So we moved now to the medial knee. So we're done with the anterior aspect of the knee, we move to the medial knee. And in the medial knee, the key structures to be evaluated in the medial knee will be the medial collateral ligament, the MCL, the meniscus, the medial meniscus, or at least the body and the anterior whole of the meniscus, and the tendons of the pes-inserine or pes-inserinus tendons insertion, which is also an area common area for knee pain, medial knee pain in patients in elderly, especially coming for pes-inserinus tendinitis. So here the patient remains in the supine position but rotates the hip externally, as you can see in this image. And so the evaluation begins with a coronal plane here, trying to find the MCL along the medial aspect of the joint line. This is typically performed by placing the probe along the knee in the true coronal plane and kind of toggling the probe anteriorly and medially until you start seeing this bulky fibrillar tissue of the MCL. So you can identify it and follow it from its insertion. So coronal view, so coronal position for the transducer on the medial joint line, and then you start toggling medially and laterally, looking for this bulky aspect of the MCL. And obviously the entire extent of the MCL should be evaluated in the long and short axis. So this is the probe positioning. This is the MCL, as you can see here, between the femur and the tibia medially. And you can also appreciate the medial meniscus and the anterior horn of the medial meniscus at this level. Now, the pes anserinus tendon, the pro position typically the pes anserinus tendon are found by following the MCL to its distal end, and then in the longitudinal plane always, then gliding the probe anteriorly until the conjoined tendon is identified. This is, so it's a slightly lower, okay, so same position medially, coronal view, and then you go from the distal part of the MCL. So this is typically what you get if you compare to the previous image. You get here, so you go down, and then you go slightly, you know, anteriorly, okay. This is the MCL distal insertion. As you can see, it ends here. And then here you start seeing the tendon insertion in this level. The pes anserinus tendon often appear as a single entity at this level, but sometimes a clear demarcation of the tendon can be seen if they're followed proximally. And here, sometimes you can get some fluid indicating a bursa, a bursite in the bursa, so the pes anserinus bursitis. But most of the time, what you get is a hypoechoic aspect at this level in favor of a pes anserinus tendinitis, with a bit of thickening at this level. So these are the structures to be checked in the medial knee. Now we move to the lateral knee, and in the lateral knee, the key structures to be evaluated will be the iliotibial band, the lateral collateral ligaments, the biceps femoris, and the lateral meniscus. Now here what we do is that we maintain the patient in the supine position, but we internally rotate the hip and slightly flex the knee here to be able to appreciate the lateral structures. So the ultrasound evaluation of the tibial band, this is the probe position. So with an internal rotation of the hip. And the iliotibial band is the first large fibrillar structure that you identified after sweeping the transducer laterally from the patellar tendon. So you get here to the patellar tendon, you sweep laterally, and the first thing that you start seeing from lateral to the patellar tendon will be the iliotibial band. And so this is a longitudinal view of the iliotibial band with you can see here, appreciate the popliteal groove containing the popliteus muscle. Iliotibial band, why is it important to check it? In the at least non-inflammatory pathology, in the mechanical pathology, it's an area where a focal thickening or surrounding fluid can be seen, especially at the distal femur, and it can indicate a band friction syndrome or iliotibial band syndrome, which is quite common in runners and in sports medicine. Now, LCL, the lateral collateral ligament. So we begin with the coronal plane, where the popliteal groove is identified. So this is a very important landmark, the popliteal groove. And then the proximal end of the transducer. So this is where you put the distal part of the transducer. Now, for the proximal end of the transducer, it's fixed at this location, and the distal end is rotated posteriorly to the fibrillar head. So it's more posterior to the iliotibial band. Remember, so as we put here, the iliotibial band is more proximal, the first structure that you see as you're going out and lateral from the patellar tendon, and more posteriorly you can appreciate now the LCL, especially by sweeping the transducer, the distal part of the transducer towards the fibrillar head. And in this oblique plane, you can appreciate here the hypoechoic fibrillar LCL, which can be identified, extending from the lateral femoral condyle to the lateral fibular head. So you look for, you put the probe at the femoral proximity here, and you should be able to see the popliteus groove, and then you sweep the probe till you be able to see the fibular head. And at this level, you can see the ligament, the fibrillary structure of the ligaments. Now, the biceps femoris, and the evaluation of the biceps femoris here, the probe position, note usually still in the same position, supine position with an internal rotation. And then you expose the lateral knee for scanning. You can see here a longitudinal view of the biceps femoris, and it's myotendinous junction. So here what you do is, so the biceps femoris is just next to the the LCL, but you can see it, you can see this, its distal insertion on the fibula. It's usually more thickened than hypoechoic, at this level. This is a normal region of a hypoechoic, aspect, probably due to anisotropy. This is something also to be, looked at, and to not be mistaken for a biceps femoris tear or any abnormality. Now, at this level, also laterally, you can position the probe in a transverse axis just posterior to the fibula once you identify the fibula, and then you'll be able to probably appreciate, have this view of the fibular, of the peroneal nerve, oval structure here coursing posteriorly to the fibula. The peroneal nerve should be hypoechoic, usually with this fascicular appearance that we know for the nerves. It's sometimes seen here, and it's can be also a source of pain, of lateral knee pain. Now we're done with the lateral knee, and we move to the posterior knee. Now, systematic examination, as we said, and we end this examination with the posterior knee. Now, obviously, for the posterior knee, the patients, for the posterior examination, the patients have to lie prone, and then you will be able to appreciate the, usually this is the position where we look for Baker cyst, mainly. So this is how we, the position to check for a popliteus cyst. The knee is extended, and the expected location for a Baker cyst is usually located between the medial head of the gastrocnemius in here, medial gastrocnemius, medial head of gastrocnemius, and the semi-membranosus tendon. So in this area, this is the area where you're supposed to see a Baker cyst, if there is any. So it's slightly medial. So it's medial to the vascular component, vascular structures. Sometimes you need to do this little of a flexion to appreciate the vessels and to be able to see the vessels. But remember that you're more medial when you're looking for a Baker cyst at this level. Obviously, ultrasound is also very important when you want to go for Baker cyst aspiration or injection, and it's particularly helpful to try, to help you to avoid these structures, the popliteal vessels. A very important pitfall here, the anisotropy of the semimembranous. We said that the Baker cyst is expected to be somewhere, when there is a Baker cyst, is expected to be between the semimembranous tendon and the medial gastrocnemius so in this area. Just remember that this tendon is subject to anisotropy, and that by changing the position, you might go from this to an anechoic or hypoechoic structure that you might take for Baker's cyst. So it is important to identify the semimembranous tendon and the gastrocnemius and use anisotropy artifact to identify, to make sure that this is a tendon and it's not something else. So that's an important pitfall. I will end this presentation by quickly showing you a few examples of a knee examination showing frequent pathology of the knee. This is a long axis view of the quadriceps tendon, so anterior examination, suprapatellar, longitudinal, and what we see in here is obviously the quadriceps tendon in here, the quadriceps fat, the prefemoral fat, and between the quadriceps and prefemoral fat, you have this hypo or anechoic material in here, which is actually joint effusion in the subquadriceps recess. So that's basically a simple one. Now, you might get a more complex joint effusion and not just an anechoic, material filling the recess. Sometimes you get something like this, which is a little bit more difficult to identify. So sometimes you have actually a synovial, you have a fluid, but you have some synovial hypertrophy, and this defines, for example, synovitis. You have this in inflammatory pathology. You can see it also in velonodular synovitis, so in pseudotumoral pathology. But you get sometimes something like this, which is more of a diffuse effusion or a material with some, internal echoes. This is typically seen in hemarthrosis, okay, when there is a bleeding inside the joints, typically in some hemopathies. Ultrasound can be also very helpful in the diagnosis of metabolic and crystal-induced diseases, and I think that you would easily agree that what you're seeing here is very suggestive of gout. These are multiple examples of gouty involvements of the patellar tendon demonstrated in the long axis of the knee. So this is the patellar tendon at the insertion of the patella, and you can see around the tendon these structures, hyperechoic structures, are all around, representing actually tophi in a chronic gout. Knees also, remember that the knee is a very common site of crystal-induced arthropathies. A longitudinal color Doppler now ultrasonography view. We haven't spoken a lot about ultrasonography or about Doppler in the knee because it's more limited. Its use is more limited in here, but it can be helpful sometimes to identify an active enthesitis in the knee, patellar or quadriceps tendon, but it can also be used to differentiate between synovitis and synovial effusion when we're not sure about the nature of the the synovial abnormality. So here we have something quite common in sports medicine. This is a longitudinal color Doppler ultrasound view of the patellar tendon, showing here a thickened tendon. You can see that the thickness is increased, a very heterogeneous aspect with the Doppler signal, an important Doppler signal, hyperemia of the proximal patellar tendon, and this is typically seen in what you call jumper's knee, in some sports pathologies that involve jumping, a lot of jumping. So this is the typical aspect of jumper's knee. One more example of non-inflammatory, I would say, pathology, or something that more of a sports medicine. I think that it's also important to know that we are sometimes by examining the knee in our patients, we are also sometimes we encounter non-inflammatory pathology, and we should be able to make a diagnosis at least to direct the patient to the right, specialist. This is a iliotibial band friction syndrome, and you can see here in a longitudinal view of the lateral knee, a very heterogeneous, fluid collection deep to the iliotibial band, which is here. This is a bursa, actually bursitis, adventitious bursitis, and consistent, with the iliotibial band friction syndrome. This needs obviously to be aspirated and injected. And last example is a complex Baker cyst here between, this is a posterior view of the knee between the medial gastrocnemius and the semimembranous here, subject to anisotropy, with some anisotropy because it looks hypoechoic. But here you have quite a huge Baker cyst, quite complex because it's not the typical anechoic, material or the cyst, filled with anechoic material. But you have, you rather have here a complex septa, echogenic, material within the Baker cyst. And this is also something what we see in chronic pathology, whether it's inflammatory or mechanical. This is the longitudinal view, the same patient showing in the long axis view, partially distended. You see here a Baker cyst. Here we are more distal along the gastrocnemius, and you can see probably here that there is the fluid is kind of dissecting along tissue planes, indicating extravasation. So this patient can actually present in a few days with not a knee pain, but probably with a leg pain and a swollen leg that can be sometimes diagnosed or, taken for DVT or, in view of the pain, the swelling and the clinical aspect. But then ultrasonography can help you to identify extravasation and Baker cyst rupture in these cases. With this, I will stop and open the discussion. Please, if you have any questions, you can ask them right now. Thank you for your attention.
Rita, for a nice presentation. Actually, we are behind our time by about 15 minutes. So it's a great pleasure for me to present my friends and dear friend, Dr. Nuran Arbaza from Ain Shams University, Cairo, Egypt. She's well known in the teaching and education regarding the ultrasound. She's certified from the ULAR as an international instructor and trainer for the ultrasound. She will give us a talk about the basic ultrasound scans of the ankle joints. Without further delay, Nuran, the floor is yours.
Thank you very much, Professor Abu Gamal, for your invitation, and thanks for all the Emirates Rheumatology Academy for this event. I will try to go faster to, compensate for the delay we have. So today I'm going to talk to you about the basic standardized ultrasound scanning of the ankle. And we're going to go through the anatomy. We're going to do the most basic things so you don't get confused, the standardized scan, and the most basic pathology concerning the joint, of course, and the tendons, and some pathology of the bone and cartilage. Well, the most important thing when you're dealing with the ankle joint is to use a large amount of gel, okay, because you have many small irregular bones. So most often your probe will need a large amount of gel to have a standoff, so you can have an acoustic window to look at the structures. So this is the most important thing. You will need often a high frequency transducer, larger than of a higher frequency than 12 megahertz, but also it's according to the build of the patient. If you have a large or overweight patient, you might need a lower frequency. So basically, the ankle joint is the joint between the tibia and the talus. So it's the tibio-talar joint. Okay, so this is the main ankle joint, and this is what does the plantarflexion and dorsiflexion. But when it comes to eversion and inversion, this is the joint between the calcaneus and the talus. The talus has been removed from this picture. Also here, the talus has been removed, but this is the articular surface of the calcaneus in those pictures, which correspond to the talus when it comes above them, which does the talocalcaneal joint, otherwise called the subtalar joint, and we will also go through that. And then we will go through some ligament. I will show you the agenda for all the structures we will see today. So we will start with the anatomy of the anterior ankle joint. Okay, when we talk about the anterior, sorry, there has been something wrong with the relations of the slides. So I will go through the agenda of the tibio-talar joint. The agenda will include the tibio-talar joint with the ankle joint, anterior scan, both longitudinal and transverse. Then the talonavicular, which would be in the foot. I will not go through that. It will be by my colleague, Professor Radwa Al-Kholi, because it belongs to the foot. And then the subtalar joint, the one between the talus and the calcaneus. Then the anterior tendon compartment, the medial tendon compartment, and the lateral tendon compartment. Also the medial ankle ligaments, which are deltoid ligament, and the lateral ankle ligament. And finally, the posterior or Achilles tendon. When we talk about the anterior longitudinal midline scan, the position of the patient would be lying supine on the examination table on his back, flat on the bed with the knee flexed and with the foot resting on the examination table. You can have a little bit of plantar flexion. This will open more space between the tibia and the talus, so you'll be able to visualize the tibio-talar scan in a more appropriate manner. Here, those arrows are showing the synovial membrane and capsule. And here, this is the triangular part of the capsule, which is more reinforced. You will always see the line of the capsule parallel to the bony cortical line of the talus. But if you find it that it's not parallel to that, it will be distended or more convex. And I will show you in pathologies how it will look. But also, if you open the Doppler signal, don't worry about two small areas of Doppler that are normally noted in this area. Those are normal feeding vessels to the ankle joint or the tibio-talar joint, and they also may associate with an overlying dorsalis pedis artery. This is when you will shift the probe to the transverse midline scan. You will also see or visualize a small, potential space without distension, but you will also see a Doppler signal corresponding to a nutrient vessel in the tibio-talar joint. What about when you will see some pathology? I'd like to show you the pathology right after the normal sonographic picture. In this part, it's more or less, the capsule is parallel to the joint line, so it's more or less normal. This also power Doppler signal, but within normal. But this is a well visualized distended tibio-talar joint, elevating the triangular part of the capsule, elevating the whole synovial membrane in capsule, and also not only synovial effusion, but you have a part which is hyperechoic here, which corresponds to the synovial hypertrophy or proliferation. Also, you can see in the transverse scan how the potential space got distended, and you can clearly see that there is synovial effusion, hypoechoic, and an other area of synovial hypertrophy. Here, it can be the a parallel line to the cortical bone, just a cartilage sign. I will show you later on when there is a deposition of uric crystals, but this can be just an artifact of the cartilage sign due to the effusion. Here is another example of basic pathology within the tibio-talar joint. You can clearly see here the tibia and the talus and the distension in between. And this is what we call complex fusion with some urate cloud. And later on, when it becomes more organized, you can call it a tophi or a tophus with an hyperechoic signals and surrounded by a hypoechoic rim. Also here in a tibio-talar joint, you can see the double contour in also a distended tibio-talar joint. When we come to the anterior longitudinal mid-foot talonavicular joint, I will not go through this one. I was just going to tell you that this is the first joint in the foot after you are done with the tibio-talar joint at the lower end of the tibia and the beginning of the talus. You go through the talus till the navicular bone to start your foot scan, but this will be with my colleague, Professor Rod. So what about the subtalar joint? The one we said it's in between the talus, okay, and the calcaneus, okay? This is the one that does the inversion and eversion, and it's called the steering wheel of the body because it changes your direction while walking. So you will scan by putting your probe on the medial malleolus for the distal end of the tibia, though it's not a part of the joint, but just to orient yourself. And you will be perpendicular to the sole or perpendicular to the examination table. You will also visualize the talus and then the calcaneus. Those are your bony landmark. So here in this view, you are visualizing the subtalar joint from the medial aspect, okay? And always the patient position is on a supine position on his back and position flat with the foot, with the knee flexed and with the foot positioned flat on the bed. Also, you can visualize the subtalar joint from the lateral aspect. You will be visualizing the lower end of the fibula or the lateral malleolus, then the talus again, and then the calcaneus, and the talocalcaneal joint is the subtalar joint. Here you are visualizing this joint from the lateral aspect. So what about the anterior ankle tendon scan? When it comes to the anterior ankle, we want to see the tibialis anterior from medial to lateral, the tibialis anterior tendon, and then the extensor hallucis longus with its insertion in the phalanx, distal phalanx of the big toe, and then the extensor digitorum tendon, which each one inserts the corresponding distal phalanx. Well, to visualize first, you can put your probe in a transverse manner, okay, just like you have done for the tibio-talar joint. Just below the tibia, you can start with the lower end of the tibia and then scan along till you have this picture of the tibialis anterior, the extensor hallucis longus, and the extensor digitorum, always from medial to lateral. And then whichever joint, whichever tendon you want to visualize in longitudinal, here you can see the tibialis anterior appearing as an oval shadow of hyperechoic signal. But when you will rotate your probe in longitudinal manner, you will visualize it as a spaghetti like pattern, fibrillar, longitudinal, parallel to each other, compact together, and so on. And this is the corresponding anatomical picture, thumb, height stick, or tibialis anterior, and the extensor hallucis longus and digitorum longus, always from medial to lateral. Of course, you can also here see the neurovascular bundle, which will be sometimes called the Mickey Mouse appearance because it appears as three little circles. How about the pathology when it comes to the anterior ankle scan? When it comes to pathology of anterior ankle scan, if you are visualizing, this is the pattern of the normal transverse scan with, for example, the tibialis anterior, just an oval hyperechoic pattern with just a potential space of hypoechogenicity around. But here, there is a distension for sure in the tenosynovium around the tibialis anterior in transverse pattern. And when you open your Doppler, like Professor Hea have explained the Doppler very nicely, you can see here the Doppler signal by the side of the tibialis anterior tendon, which is mainly in the synovial sheath of the tendon, but also there are parts of our Doppler within the tendon. When it comes to the longitudinal, this is the normal longitudinal scan, and this is another longitudinal scan with distension of the tenosynovium around it. And this is its corresponding transverse scan. Of course, here you can see synovial hypertrophy within the synovial sheath. The medial ankle tendon scan, and this is very important because the medial compartment is always or frequently affected in rheumatoid arthritis and in psoriatic arthritis as well. So when you will put your probe just above the medial malleolus, okay, and it will be directed in this way, okay, just above the medial malleolus, and then scan posterior and perpendicular to the axis of the tendons. You will visualize the tibialis posterior, flexor digitorum longus, and flexor hallucis longus. This is the pathology, okay, and this is the positioning of the probe, and this is when you will study. This is normal again, the tibialis posterior, the flexor digitorum, and the flexor hallucis, and the neurovascular bundle. This is in transverse, and this is in longitudinal. As you can see, in longitudinal, you will have to follow the pattern, or you have to follow the course of the tendons. Also, we can see here an example of tenosynovitis in the tibialis posterior tendon with marked hypertrophy of the synovial sheath and a power Doppler signal when we apply it. Here, it's another example, the example of tendon tear within the tibialis posterior tendon. You can see a transverse as a discontinuity in the oval shape of the tendon, and here as if it is two tendon or the fibers are separated in the longitudinal aspect as well. When it comes to the lateral tendon scan, which are the peroneus longus and brevis, those are often affected in rheumatoid arthritis and in psoriatic arthritis, sometimes making the patient limping. Those are very important for us. You also go to the scan with a little obliquity over the lateral malleolus, and then you can scan more proximally till you have the muscles, and then scan more distally, and then scan in this anterior part too, with a little bit of inclination, okay, towards the little toe, so you can see the longitudinal scan of the peroneus longus and brevis. You can follow the insertion of the peroneus brevis till the 5th metatarsal and the peroneus longus till the 1st metatarsal base and the medial cuboid in the foot, but I believe maybe this will come in the foot. What we are concerned here, that you will see two tendons just above the lateral malleolus of the fibula. This is the bone cortex of the fibula, this part, and then a little tendon which is close to the bone, which is the peroneus brevis, always closer to the bone in longitudinal and in transverse, and another tendon which is larger and more away from the bone, which is the peroneus longus. Once there is a tenosynovitis, you will see those two tightly packed tendons, always tightly packed together in the synovial sheath, that now are separated by synovial fusion and synovial hypertrophy. Also, this will be very evident in longitudinal scan. Remember not to apply very high compression, or else if it's only a minute tenosynovitis, you will not get it. And remember to apply the power Doppler like we have said earlier. This is another example of the lateral and also in the medial, sometimes in the lateral or sometimes in the medial. This is from the peroneus brevis, the first picture, and this is from the tibialis anterior, but both are showing tophi, which are presented in the hyperechoic mass, which is oval or rounded, but surrounded by hypoechoic part or material. Also here, you can see another tophus with some erosions underneath the bone of the medial ankle. Also here, you can see the power Doppler when we apply it on that tophus. What about the medial ligaments of the ankle? We will go through these as only the standardized scan will not manage or not discuss their pathology today, because this is more like sports medicine, more or intermediate or even advanced level. But to have a general knowledge about the deltoid ligament, we have deep components of the deltoid ligament and superficial component. To make things more easy, these parts, the violet, the red, and the blue, are the posterior tibiotalar and anterior tibiotalar. Actually, the anterior tibiotalar, sometimes it's not present, and the posterior tibiotalar, it has a superficial part and a deep part. Then you have a part that is the tibio-calcaneal, okay, part, which is the red part, excuse me. And then you have the orange part, which is the tibio-spring ligament. This green part is the spring ligament. And then the yellow part, the red one is, as I said right now, the tibio-talar. The anterior tibio-talar part is the blue, light blue part here. So again, the deep posterior tibiotalar, the superficial posterior tibiotalar, and then here, this one light blue one is the anterior tibiotalar. The red one would be the tibio-calcaneal, and then the orange one would be the tibio-spring part of the deltoid ligament, and then the tibio-navicular, which is the yellow one. Well, to make things easier, it's like a fan shape. You will start your scan by being parallel to the sole of the foot, but then you will fix the probe on the medial malleolus, and you will go like a fan shape with the probe. I will show you right now. So the first to be scanned here is the posterior tibiotalar. The posterior tibiotalar goes from the medial malleolus until the talus. And here you can see this part in longitudinal, but you can also shift your probe and make it just perpendicular to the sole. Just here it's perpendicular to the sole. You can make it also parallel all the way to the sole, and you see it in both directions. If you do it while the ankle is resting on the examination table, you will have this picture with a part not appearing here from the tibiotalar part, but if you put the ankle in dorsiflexion, this part will appear from the tibiotalar part of the deltoid ligament. Then you will go a little bit more anterior with the inferior part of the probe, always keeping the upper part of the probe fixed on the medial malleolus, and then you will be able to see this is the medial malleolus, and then you will see it inserting in the calcaneus. This is the tibio-calcaneal part. Also here, you can do or exaggerate it as some dorsiflexion with the foot now not flat on the examination bed, but lying on the medial, on the lateral side, exposed the medial side, and then you will go like a fan shape. You will go now a little bit more anterior to visualize the tibio-spring ligament, and then more and more anterior to visualize the tibio navicular part of the ligament. What about the anterior and the lateral ligaments? Well, the most important ligaments to visualize here, first, the anterior talofibular ligament, which is often affected or often sprained, and then the anterior inferior tibiofibular ligament between the fibula and the tibia. And then we have also the calcaneofibular ligament, which is often also subjected to strain. Well, how can we visualize those ligaments? First one is the anterior talofibular ligament. For the anterior talofibular ligament, here you will position the probe parallel to the examination bed and to the sole of the foot, so that you can see this one with the blue arrow, which is extending from the tibia. Sorry, here it's written talofibular, from tibio. Yes, the talofibular, sorry, ligament between the lateral malleolus and the talus. Okay, so this is the lateral malleolus and this is the talus. It's the talofibular ligament, anterior talofibular ligament. You will put your probe like this and you will see the tendon extending in this way between the lateral malleolus of the tibia and the talus. And then if you fix your probe over the lateral malleolus and just shift for 45 degrees upwards, here you will see the tibiofibular ligament between the lateral malleolus of the fibula and the tibia. It takes a 45 degrees upward to see this ligament, and you will visualize it as such, just between the fibula and the tibia. Also, you can do the calcaneofibular ligament. The calcaneofibular ligament is between the fibula here and the calcaneus. You will need also to do some exaggerated dorsiflexion to visualize the tendon in a better way. This is the picture without dorsiflexion. And then this is the picture with the dorsiflexion. This is the lateral malleolus, and this is the calcaneus, and the tendon in between marked with the arrowheads. So this is a more large picture with the dorsiflexion, and it appears better this way, the calcaneofibular ligament. Okay, when it comes to the Achilles, the patient will be lying prone, and we will examine the Achilles from the posterior aspect. You will put your probe in a posterior longitudinal manner to obtain this picture. And this is a very important area of interest because the Achilles is curved here, okay? And you will need to follow the the curve of the Achilles tendon, or do a little bit of tilting with the inferior end of the probe, so you can obliterate this anisotropy and check if there is any heterogeneity here or any pathology. Also, you can rotate your probe transversely to see the Achilles tendon in a transverse manner and measure its dimensions. Usually, the thickness of the Achilles would be 6.1 millimeters in average. Well, this is another picture for you showing the longitudinal scan and how anisotropy can be affecting here. So you will have to tilt the probe to obliterate that and see it as white as the normal part of the tendon. And this is the transverse scan. Again, if you do a little bit of tilting, also there will be anisotropy and you will not be visualizing the Achilles. And then you will, again, to have it in a better hyperechoic normal pattern of the Achilles. So you will have a better discrimination of the contour of the Achilles. So let's see the pathology of the Achilles tendon. One of the most important pathologies, of course, is endotheliopathies. Here there is an erosion in the calcaneus below the Achilles tendon. There is a heterogeneity and hypoechogenicity of the endothelial part of the tendon attached to the calcaneus. There is also a power Doppler signal, but that is extended also beyond the endothelial part. So there is both tendinitis and enthesitis. Here, there is a retrocalcaneal bursa that is also distended. Okay, so you can see that also here we can see an enthesophyte from the surface of the bone. We can see here another erosion and some power Doppler signals. And here another intensophyte. In some cases, you will see above the Achilles tendon, retrocalcaneal bursa, just posterior to the Achilles tendon, between the tendon and the skin. And you can see it here in transverse view as well. And sometimes it will be not a well-demarcated area like the retrocalcaneal bursa or subcutaneous bursa, but it will be a paratendinitis. It goes also with a tendinosis, with enlargement or thickening of the Achilles tendon. Sometimes you will see the inside of the Achilles tendon as if separated from each other or exhibiting an intrasubstance tears. Sometimes you will also see rheumatoid nodule or sometimes a tophus. Here, this one is showing a rheumatoid nodule. Here, the hypoechoic part just beside the Achilles tendon. Rheumatoid nodule will appear at a hypoechoic nodule with increased through transmission below it, with a hyperechoic signal below it due to through transmission artifact. Also, sometimes you will see a tophus like that. It's a hyperechoic oval signal or oval mass with hypoechogenicity around. Another example of intensophyte that you can visualize in longitudinal and that you can verify also in transverse scan. And thank you so much. I tried to save, but it's only 5 minutes that I've saved. Thank you so much.
Thank you, Nuran. Brilliant talk as always. I know the time is late, but it's not your fault. And thanks for your making your job on time. So now we are moving to our last speaker, Dr. Radwa Kholi. We are happy to be with us today. She presented a talk about the ultrasound of the foot. Professor Radwa, she's a professor of rheumatology at Atlanta University, and she's already certified from the ULAR as an international instructor and trainer of the ultrasound. And without further delay, Radwa, the floor is yours.
Thanks, Professor Ahmed Al-Gamal, and for the Emirates Rheumatology Academy and all for invitation. I will start ultrasound of the foot. I will start, okay. My agenda is the anatomy, probe and patient position, scanning protocol, indication for ultrasound of the foot, and the common pathology of the foot. We will start with the anatomy. The anatomy of the foot is complex, but I will try to simplify. As we hear from Professor Nuran, we start with the ankle. It's formed by articulation between the tibia and talus, and then the tibia talus has an inferior articulation also with the calcaneal in between the subtalar joint. Anterior part of the talus at the medial aspect of the foot is articulate with the navicular, and navicular in turn articulate with the medial cuneiform, middle, and lateral cuneiform. So we have talus, navicular, medial, middle, and the lateral cuneiform, which in turn articulate with the metatarsal bone. Going to the lateral aspect, we have a calcaneal bone articulated with the kyphoid and metatarsal bone of the fourth and fifth toe. This is the important bone, the joint and the functional unit. In here is articulation. We have an ankle joint formed between the tibia and the talus, and the subtalar joint formed between the talus and the calcaneal. And in the foot, we have the talus, navicular, and calcaneokyphoid called Chopard joint, and between the cuneiform, between the cuneiform, medial, middle, and the lateral, and the metatarsal bone. And the kyphoid with the metatarsal bone or tarsometatarsal joint is called Lisfranc joint. And we have also the metatarsophalangeal joint and interphalangeal joint. Okay, going to the tendon. It's the same as we scanning in the ankle, going to the dorsal aspect. Here is from the medial to lateral, we have tibialis anterior, extensor hallucis, and extensor digitorum. This tendon is continue in the mid-foot and forefoot to its insertion in the two. We will see it, and when you're scanning it, is going deep in the plantar aspect and previous inserted into the fifth metatarsal. Going to the medial aspect of the foot, we have also three tendons, tibialis posterior, which go to its insertion in navicular, and the flexor digitorum to inserted in the plantar aspect of the toe. All the tendons in the ankle and the foot have a synovial sheath that end just before its insertion, and in the plantar aspect we have a connective tissue structure, plantar fasciitis, which is attached from the calcaneal, medial calcaneal tubercle, and in the metatarsal bone. We have in the foot one metatarsal tarsa. Okay. Ultrasound probe scanning. Okay, we will start the scanning of the foot. We starting position as the same as the ankle. The patient is supine or seated with the knee flexed to 90 degrees, and the foot is flat on the examination table. And we start with our probe in a long axis in the mid view of the ankle joint. Okay, we use usually for the ankle and the foot linear probe with a wide frequency from 7 to 15 megahertz, and a high frequency is better to details and superficial scanning. We can use a hockey stick probe for a small footprint in a long axis and a short axis as usual. We start our scanning protocol for the foot. We start usually from proximal to distal, and we start with the dorsal foot scan. We have to scanning the mid foot joint as we talk about. We scan talonavicular, navicular cuneiform, and calcaneocupoid joint. Going to the dorsal aspect of forefoot, metatarsophalangeal joint. Going to the medial and the lateral foot, we will scanning the medial aspect of first metatarsophalangeal joint and the lateral aspect of the fifth metatarsophalangeal joint, and also scanning the lateral pronaos in the lateral aspect, pronaos previous tendon insertion, and tibialis posterior insertion. Finally, a plantar foot, we will scan the plantar fascia and a plantar aspect of the metatarsophalangeal joint and with a flexor tendon. Starting, as we say, we will start with the long axis view with the probe in the mid position of the ankle as we start in the ankle, and we will see the first bone we will see will be the tibia, and as we see in the ankle joint, and then we go to the talus. The talus has three parts, dome, neck, and the head. then the talus end and start of the navicular bone. The joint in between is appearing as a small unequal space between the 2 points if not distended, and here is the talonavicular joint enclosed, and we may have a capsule or ligament attached above it. Okay, going from the navicular slightly, we start from proximal to distal, going from the talus navicular, so will be cuneiform, medial, middle, and the lateral cuneiform, and from the cuneiform we will continue to the metatarsal bone. When we scanning the mid joint, we have a 3 tendon in a dorsal aspect from medial to lateral. We have tibialis anterior tendon, which will be inserted into the medial cuneiform. The tendon appear as hyperechoic fibral line above the medial cuneiform to its insertion to medial cuneiform and first metatarsal. Going slightly lateral will be the tendon. We will see hyperechoic fibral line will be extensor hallucis longus to its insertion. This is, as we say, talus, navicular, and cuneiform. Going slightly more lateral tendon, and if we don't know which tendon, we can ask the patient to extend his big toe or the two other two to show which tendon we are in. Okay, going slightly lateral aspect opposite to the fourth and the fifth two, we will see the calcaneal bone. We put our probe like this, so the structure we will see is a calcaneal bone and kyphoid bone with the hyperechoic fiber is the dorsal calcaneo-kyphoid ligament. Okay, going to the dorsal forefoot, we start from proximal to the distal aspect. We will start with the first metatarsophalangeal joint. We will see a first metatarsophalangeal head with an echoic or plaque cartilage and a proximal phalanx. And in between, we don't see the synovial recess except there is a minimal fluid in it. And above the extensor hallucis tendon, which is hyperechoic fiber above. Sweeping to the lateral aspect and starting scanning is from the second to the fifth metatarsophalangeal. And we will see the
That's okay. It's okay. Thanks for being with us.
Sorry. Our dorsal forefoot scan from the second to fifth metatarsophalangeal in a longitudinal and along the axis. As we saw, we will see the same structure. We see the metatarsal bone with the metatarsal head and the proximal phalanx with the synovial joint capsule and the synovial recess and the above hyperechoic line of the extensor digitorum tendon. Going slightly distal, we will see the proximal phalanx and proximal interphalangeal joint and the distal interphalangeal joint. Okay. Turning our probe to the transverse, we will see the metatarsal head with the cartilage above, and the extensor tendon will be rounded and the vessels in between. Okay. We say we have to scanning the medial aspect of first metatarsal and the lateral aspect of the fifth metatarsal as it's accessible when we try to find an erosion as we scan in the finger. We will see the same structure, the metatarsal bone and the proximal phalanx, and we will assess the continuity of the bone for any detection of early erosion. In the lateral foot, we will see as we start in the ankle, we have two tendons, peroneus longus and brevis. We say that peroneus longus will go deep in the plantar aspect and the peroneus brevis inserted to the fifth metatarsal. I will turn my probe to the long axis and follow it in the lateral aspect of the foot. The tendon of peroneus brevis appear hyperechoic line till its attachment or insertion to the fifth metatarsal head. For the medial aspect, the same. When we put our probe in the transverse view at the ankle, we see the three tendons, tibialis posterior, flexor digitorum, vessels, and the flexor hallucis. We will turn the flexor digitorum and the flexor hallucis will go in the plantar aspect to its insertion. So we will follow only the tibialis posterior, turning our probe to the long axis and going slide the medial aspect to its insertion at the navicular bone. Will appear hyperechoic fiber to the navicular bone. Finally, going to the plantar aspect, ask the patient to change its position to the prone, with the foot is hanging from the examination bed or slightly in a dorsiflexion, and we will put our probe in a long axis in the medial aspect of in the middle of the calcaneal, slightly medial. We will see the calcaneal cone, and the plantar fascia will appear as a hyperechoic, isoechoic to the tendons and the ligament fiber, which is parallel to each other hyperechoic fiber. This is the plantar fascia. We will scan in the plantar aspect also, the plantar aspect of the metatarsophalangeal joint in long axis and the short axis. We will put our probe in a long axis opposite to the metatarsal bone, and we will see the metatarsal head and proximal phalanx. In between, there is a hyperechoic fibrocartilaginous structure, is a plantar plate, and the above is the flexor hallucis or flexor digitorum tendon, according to the two. Turning our probe to the transverse, we will see the head of the metatarsal and with the flexor digitorum tendon, and in between the vessels and nerve. Finally, why we scanning the foot? Rheumatological indication for any joint, we have to assess effusion or synovitis. For tendon, we have tenosynovitis, tendinosis, encephalopathy. For plantar fascia, specific plantar fasciitis, bursitis. For bone, we have erosion or osteophytes. Others, subcutaneous nodules and tophi or ganglionic cysts. For the midfoot, we have tibialis anterior tendinitis or midfoot arthritis. For foot, we have metatarsophalangeal synovitis, microcrystalline deposition of the tophi, as we say, metatarsophalangeal erosion, and Morton's neurone. We will start, I show some view of the synovitis. Here is the first metatarsophalangeal. We say we don't see the synovial recess except it's distended and full of fluid and the synovial hypertrophy, which appear as hypoechoic or anechoic. Okay, this is the first metatarsal, and this is the synovitis extending. Okay, and here is the talus navicular, and with talonavicular synovitis. Going to the gout, here is the first also metatarsal with synovial hypertrophy and the hyperechoic deposition of the crystalline to the upper surface of the cartilage, forming double contour, and the deposition of the tophi in a first metatarsophalangeal joint. In osteoarthritis, it appears as a cortical irregularities with osteophytes formation, may be as talonavicular, navicular, cuneiform, which is the osteophytes is appearing step up from the bone. So it's here is the cortical, and we see a step up bone above it. Okay, and also in a first metatarsal, we can see the osteophytes and cortical irregularity with a step up osteophytes. For the tibialis anterior, as we say, it's insertion. Okay, we see here is a tendinopathy with hypoechoic thickness and the loss of the fibrillar pattern and at its insertion side. Okay, here is the tophi with the tenosynovitis around the tibialis anterior tendon. Going to the bone lesion, you will see the erosion. We say erosion is a here is the defect in the cortex, but not a step up, it's going down. Here is the erosion in a first metatarsophalangeal joint, and we can measure the dimension of the erosion. Okay. The plantar fascia, the most common pathology for plantar fascia, plantar fasciitis, it's hypoechoic thickness and convexity of the plantar fascia at its origin from the calcaneal origin. It's from here, it's hypoechoic thickness. This is the normal plantar fascia, and here is the hypoechoic with convexity of the fascia. And we can measure its normal thickness is about at its origin from the calcaneal bone. It's about 4 millimeters, and it's increasing. It's suggesting that it's a plantar fasciitis. For the forefoot, the most common we see in forefoot between the two heads is Morton's neuroma or bursitis, metatarsal bursitis. The Morton neuroma is a hypoechoic lesion between the metatarsal head when we're scanning in a transverse. It's non-compressible and may not have Doppler signal and have a special technique to scanning in a molder with the squeezing of the metatarsal bone. The metatarsal bursitis is more hypoechoic or unechoic and compressible, may or may not have a Doppler signal. So to conclude, the sonographic anatomy of the foot is complex but very useful to rheumatologists. We can use it as to quick and accurate localization of the characteristic pathology of the foot, have advantage of dynamic assessment over other imaging modality, also the Doppler integration assessment of vascularity and activity. This is my references. Thank you.
Thanks to Radwa for a nice presentation and year of effort to present with us today. And I'm calling all the faculty to be here for answering the questions. No, it's okay, Radwa. Excellent talk. I know that it's always happening. Don't worry. Now calling all the speakers to open their camera to be with us in discussing the question and answer session. We have just a few questions here. I can see it. Georgia, if you can share all the questions in the chat box. Before starting the question, I'm really thankful for all of you to be with us today, and for the second day. Actually, we covered all the subjects of the basic scanning techniques, and I appreciate also your commitment in education and learning of and spreading the knowledge of ultrasound among our trainees and fellows. For question from Dr. Fagazi Al-Tamimi, what are the musculoskeletal ultrasound finding in transient hip synovitis? Dr. Slavitsa, if you can answer.
Sorry, I didn't see the question.
So if you can hear me, is a question about the ultrasound finding in transient hip synovitis.
In transit?
Yes.
You probably someone mean about osteonecrosis.
Not osteonecrosis, Slavica, about the transient hip synovitis. It's one of the causes of the painful hip syndromes, about transient inflammation of the hip.
Yes, transit. Yes, I understand that this occurs sometimes, but regarding the ultrasound finding, I didn't find any difference between fluid into a joint and this kind of fluid. I can't find
different ultrasound findings. That's true, because it's just synovitis and inflammation. So ultrasound definition of synovitis is applied also for all kinds of synovitis, and effusion is the same.
Yes, so, yes.
Just a hypoechoic lesion intra-articular.
Yes. The only difference is when we suspecting in blood inside the joint. There is only difference in fluid appearance. It's more chemogenic, it's more hyperechoic. Otherwise, the fluid into a joint is the same presentation.
Okay. We have another question from Abdelatif Al-Arfag about the tendon thickness. For Nuran, if you're going to measure the Achilles tendon, Nuran, you take the measurement within after the paratenon or including the paratenon thickness? Nuran, can you hear us?
Yes, I just unmuted. I'm sorry. I heard the question. I don't include the paratenon.
Okay, so we're relying mainly on the tendon thickness itself, pure tendon thickness. And actually, this
yes,
all
in the fibrillar pattern, I meant. Yes.
Okay. This applied for all tendon measurements.
Yes, thank you, Professor Abou-Gamal.
Okay. For another question from
exactly.
Can we depend on ultrasound for diagnosis of meniscus affection? For Rita is not here with us, so I can answer this question about the meniscus. Yes, we can see the meniscal change, especially the crystal deposits, and also can differentiate between meniscal degeneration and tear, especially in the outer part. But to have a complete vision of the all lesion inside the meniscus, you have to rely on MRI. So MRI is more superior for meniscal lesion over the ultrasound at that indication. More questions. Thank you so much for the valuable lecture. Would you prefer in-plane or out-plane injection of the Baker cyst? Okay, there is a question for the knee. For the Baker cyst aspiration, we always do it in plane longitudinal scan. So we're visualizing the tip of the needle with the shaft of the needle always to make sure that we're getting aspiration of all pockets of the Baker cyst itself. Another question. Thank you for the presentation. How effective is ultrasound-guided genicular nerve block for chronic knee pain and osteoarthritis knee? Is it safe procedure? Yes, this is one of the pain treatment are usually frequently used under fluorotherapy and perineural injections, especially using the compound glucose and saline injections. And it is safe, but the efficacy and durability is the side of the questions. Actually, it's not about the safety. Safety is perfect. More question. What about posterior tibial nerve at the level of tarsal tunnel? Nuran again. Nuran, you are muted again.
Well, yes, I don't work when it comes to neuromuscular. I just refer to my friends with more experience in the nerve block. I don't do that personally.
I think this as a site of entrapment, we can apply all the criteria of nerve entrapment. You can see proximal edema of the nerve just before the retinacula, and also you can see what's called the V sign of compression, and also the cross-sectional area of the nerve. We can compare it also with the other side. This is the general rules in nerve entrapment. You can apply it regardless the side.
That's great. Great.
Okay. Following the questions here. Can we differentiate mechanical from inflammatory encephalitis in ultrasound? This is the everyday question. I answered yesterday, so I proceed this and answering to Radwa. You can answer.
How to differentiate between mechanical
and inflammatory encephalitis.
encephalitis?
Yes.
Yeah. We don't have the inflammatory encephalitis. We will see the pathology around the 2 milli according to the Doppler definition of the encephalitis. We have to assess it about 2 milli from the encephalial sites with the Doppler signal presented around. When we have a course encephalitis, we have an erosion more specific for the inflammatory. Even it can occur in a mechanical, but the mechanical associated with more tendinopathy of the tendon, more away from the 2 milli from the insertion sites. So we have a special spaces. We don't assess the inflammatory encephalitis in one incisus, but we can assess the other incisus if we find more than one pathology. We don't depend at the tendon Achilles only. We can scanning the patellar tendon at its proximal and distal insertion, and also quadriceps tendon to confirm, and even in the upper limb also triceps insertion.
Okay, and also it's still a valid point to have the both together based on the Umerect classification of the chromic damage of the CCL attachments, the presence of calcification, for example, and already the bone encephalophyte or osteophytes. This could happen also in long-standing inflammatory encephalitis as part of the healing process of the encephalitis. It's better to always ask about the classification of the acute encephalitis or the chronic damage encephalitis. Is actually the most important part to answer. But to have a clear-cut differentiation between mechanical and inflammatory encephalitis, even with more efficient imaging modalities for the bone itself, like MRIs, you still have queries. Also, you cannot clearly differentiate between the types, because we also overlap in some patient scenarios. All the questions answered. I'd like to ask Hala, give us a very nice talk about the rough topic, which is Doppler. So what advice you are giving to for all the genuine who start to practice ultrasound regarding the Doppler? What is the most valuable advice for them from your side?
Thank you for the question, and thank you for the invitation. The best advice is to give yourself time adjusting the machine and trying to gain skill, because these tips you have to do, like the adequate pressure. So if you put too much pressure, you will damp the signal, and if you take all the pressure, you'll not get any signal. To be acquainted with the Doppler artifacts, all these are important tips, and especially also, as I said in my presentation, that you have to have time adjusting your machine, because every machine has its settings, and so you have to have enough time to adjust your machine and to be to know the proper setup for it. And this is, I think, the most important tips.
Yes, because even different brands of machines have different sensitivity, even for Doppler signals.
Right.
Savita, what do you?
Sorry, can I add some advices more?
Yes, please.
I think that is a very suggestive way is to ask your technician of ultrasound machine, because they are more efficient than us, of course, and they are always willing to help us.
Okay, did you mean the
Sure, I will.
the machine operator, Savitsa? That's me.
Yes, a technician
company.
of the.
Yes.
I mean,
Company, yeah.
yes, the people who divided, who sell us the ultrasound machine.
Yes, that's a good advice.
Yes.
I was going to ask you, Savitsa, about the lateral hip pain with ultrasound. What do you think about the what is the most frequent lesion you can see among your patients?
Okay, the lateral hip pain is very often in our everyday clinical practice, as we know very well. For my point of view, I found most often peritrochanteritis as cause of this pain. I, of course, always need ultrasound examination in order to confirm this finding, but in that case, I usually found some pathology at the level of trochanter, greater trochanter. The most frequent is bone irregularity, but many times I found many calcification at that level, sometimes with active power Doppler signal, but it's very important and very useful area to apply ultrasound method in our everyday clinical practice. And it is very easy to suspect this pathology. Of course, patients have very strong pain and need help. And I think that people who perform, the doctors who perform ultrasound examination have some advantages in treatment that patient, because we have ultrasound examination.
Yes, that's true. And usually, I'm not seeing a lot of bursitis on the lateral hip, or most of our lesions are seeing is mainly related to the tendon and enthesitis on that side.
Yes, sometimes bursitis is present, but it rarely occur. I think enthesitis is much more present. I mean, enthesitis, calcification and bone irregularity, not bursitis.
Okay.
But sometimes we have also bursitis as well.
Okay. Rado, what would you prefer, ultrasound guided injection of the plantar fascia? What's your approach?
Always using online scanning, inline scanning with the transverse. I turn my assessment to the lesion in a long axis, turning my probe to the transverse, and then be in line with the needle and see the injectate above the sides of the plantar fascia. This is the most preferred. I don't prefer out of plane.
Yes, that's actually my approach also. I'm always injecting transverse in-plane injection. But you are directing the needle inside the fascia or just superficial on the top?
Above the fascia, just between the fat and the fascia, above the fascia, not inside the substance of the fascia.
Yes,
especially if it's steroid.
Yes, this is my approach also, because there is some practice that injection even inside the fascia itself.
I know that other injecting deep to the fascia, but it's very painful between the bone and fascia, but it's very painful to the patient.
And also carry risk of rupture or partial tear even for
the fluid when enters the fascia, and pressure of the fluid inducing and rupture of the fascia.
This is the most safe. Yes, I do agree in this. Nuran, what do you prefer how to inject the ankle with ultrasound guidance?
Well, actually, I prefer the anterior, but I use the out of plane. I use the out of plane, and sometimes I, use the Doppler to make sure that when I inject, I see very well if there is any vessel above, to be away from the vessel. Maybe I go a little bit medial or in the lateral recess or in the medial recess, to avoid any vessel just above. And sometimes I go just out of plane, and with the power Doppler on, I'm sure that I will not be penetrating any vessel.
Yes, and also by the Doppler opening during injection, he gives you the flow of the injected material as a Doppler.
Yes, which is excellent. It gives you more accentuated flow, and then and it's very easy.
Yes, to make sure this is already inside the joints. Okay.
Yes.
So with this, actually, I'm very happy to have you all today. Actually, I'm very lucky to have this great faculty with me today and yesterday to presenting this course. I'm really thankful for every minute you spent in talking and preparing your slides. And thanks for all our attendees from all over the countries. We have, till yesterday, we have 44 different countries registered with us, with over 527 registration, which is a great number for a basic course, and which is a great impact for all of you in this 2 days course. And thanks again for the Emirates Pathology Academy for sponsoring and designing this mainly dedicated educational program for our trainees and the fellows in the region amongst different countries. And I hope next time we can make it face-to-face and see you all. Have a very nice evening and good night for you all in different parts. And thanks for our attendees, and thanks for our organizer, Infomed. Georgia was us today and Nancy was yesterday. Thank you all and goodbye.
Thank you and happy Eid.
Hyrimoz by your specialist. Hyrimoz is available as a pre-filled syringe and pre-filled pen. The sensor-ready pen is a device that injects a dose of 40 milligrams, and this video will show you how to inject with it. The sensor-ready pen will give you the exact dose prescribed to you by your specialist. It's been designed with you, the patient, in mind, and you should familiarize yourself with the different parts. The sensor-ready pen is made up of a cap, which contains the internal needle cover to protect the needle, a needle guard for safety during handling,